systemic therapy of metastatic castration-sensitive naive prostate cancer. Presenter, Dr. Medical Oncologist Petrauskas from National Cancer Institute. Please.
Hello, dear colleagues. My name is Petrauskas, and today I'm going to talk about systemic therapy on metastatic castration-sensitive prostate cancer. So, as we all know, men with advanced prostate cancer have evidence of metastatic disease at presentation, while others develop metastatic disease after definitive treatment of localized disease. In some cases, this might be manifested only by elevated PSA levels. The majority of men in all these three groups have one thing in common: they are not receiving long-term ADT, and serum testosterone levels are typically above 50 nanograms per deciliter. These men are considered to have castration-sensitive prostate cancer. So patients with metastatic hormone-sensitive prostate cancer have M1 disease and still responds to ADT. These patients don't have to be ADT naive, but they also might receive ADT in previous lines of treatment, for example, in adjuvant settings. But afterwards they completely recovered function of testicle function. So a critical role of androgens in stimulating prostate cancer growth was established in 1941 by Charles Huggins. These findings led to the development of androgen deprivative therapy as part of a treatment for patients with advanced prostate cancer. So we can achieve androgen deprivation by two radical different methods. So one of them is surgical orchectomy, and other is medical castration. In comparing efficiency of these two treatments, they are completely the same in long term, but their difference is in time of the onset of the treatment and of the effect. So surgical orchectomy level of testosterone drops immediately after intervention, while medical castration we have to wait a little bit for effect. So when we use gonadotropin releasing hormone agonist, the effect we reach effect in about a month. Of course, we have to take in account a flare effect. So doctors that prescribe this kind of treatment usually go additionally with first generation antiandrogens, and then only then patient can avoid this kind of phenomenon. Other kind of treatment is gonadotropin releasing hormone antagonist, which suppresses testicular function within a couple of days. Long-term experience and safety in gonadotropin releasing agonist has made it a preferred approach in many practices. So if in lots of cases, almost all of cases when patients receive gonadotropin releasing hormone agonist, so this is almost 100% usable in Lithuania. So doctors rarely prescribe antagonists. So other question, when we should start the treatment? The answer is quite simple: as soon as possible. And because when there was a published trial in 2006, when a phase 3 trial proved that patients that have a higher PSA levels and at the start of a treatment have worse outcome. So when we have a patient with metastatic disease, ADT should be started as soon as possible. I think we should talk before going into the treatment itself is to discuss low volume disease and high volume disease. So patients with high volume disease have to have more than 4 bone metastases, of which one of metastases would be in beyond pelvis or vertebral column. And there should also be a visceral metastasis. Of course, there can be only visceral metastasis, and then we define the disease as high volume. In 2022, we have a lot of treatment options on our hands. They include next generation androgen receptor inhibitors and chemo. Of course, in Lithuania, there's only reimbursement of docetaxel in hormone sensitive settings. Of course, in a couple of years, this might change. So I think we should talk about every possibilities, because when the time comes that reimbursement comes, then we will be able to prescribe more personalized medicine for our patients. So first two trials I would like to present is a Charter trial and Stampede trial. These are successful trials. There was a trial called GETUC 15, which failed to show significant improvement in overall survival in patients receiving docetaxel. So I won't talk about that trial. So Charter trial and Stampede trial included patients which have hormone-sensitive disease, and as you can see, they reached their goals. So in Charter trial, there's definitely benefit of overall survival in patients receiving docetaxel, and also there is a Stampede trial which patients have overall survival significant improved with addition of docetaxel. When there was done a subgroup analysis, we can see that only patients with high volume disease benefit from addition of docetaxel. Patients with low volume disease do not do that, and the same thing will be shown in Stampede trial. Of course, every time we talk about patients receiving chemo, all the doctors are aware of it might worsen the patient's quality of life. So, of course, initial starting of docetaxel reduces the quality of life at the beginning, but after the end of the chemo, which usually ends within a half a year, patients regain full function, and as you can see, compared to the standard treatment, so ADT alone, patients gain more benefit from it in long term. Another trial, Stampede, as I mentioned, showed similar results. Of course, they were not statistically significant, only came close to it. So with high burden disease, the results didn't reach 0.05, but came close to it. And with low burden disease, it showed the similar results as in Charter trial. So no added benefit from addition of docetaxel and chemotherapy in low burden disease. So next, I would like to talk about next generation androgen receptor inhibitors. These drugs are well known for medical oncologists in Lithuania, but unfortunately only in settings of hormone-resistant disease. But as I said, in a couple of years, I hope this will change, and we might prescribe our patients with hormone-sensitive disease. But for now, we're left only with docetaxel. So this is the part of the future in Lithuania. And as I told you, the drugs are well known, and we know all the side effects of them. We use them only in hormone-resistant settings. So first trial that I would like to talk about is abiraterone, which was analyzed in Latitude and Stampede trials. As you will see later, Stampede trial is a large trial which involves more than 2,000 people. It's multi-arm treatment which analyzes a lot of perspectives of treatment in treating prostate cancer patients, and you will see a lot of Stampede trials in my presentation. So both of these trials included patients with analyzed patients with high volume disease, high risk by high volume disease, and as you can see, both Stampede and Latitude trials reached their goal to prove that abiraterone is a more efficient way of treating patients compared to standard ADT. The quality of life with patients that used abiraterone is much better than ADT alone, as you can see from the slide. Next slide I would like to talk with is a Titan trial. In this trial, there was analyzed of upload plus ADT, and it was compared to ADT alone. In this trial, there was a patient that might have been exposed to prior docetaxel, so there is a lot of mix in this trial. So you will see in the results. As you can see, patients that received progression apalutamide improved progression-free survival for patients receiving it compared to ADT alone. But and patients, of course, that received the apalutamide, it also benefited in overall survival. So not much as progression-free survival, but still potent drug that also benefit the patient, improves quality of life of patients and prolongs their life and progression-free survival. About quality of life, it didn't improve their quality of life, but actually remained the same compared to the placebo, so ADT alone. Other trial I would like to talk is Archer study, where enzalutamide was studied. So in this trial, patients who could involve with high or low burden disease. Patients could previously receive docetaxel, so it's also a quite large study with more than 1,000 patients receiving enzalutamide. As you can see, the results are very good, and enzalutamide also proves its worthiness. And compared to the standard ADT alone, it also improved quality. It also improved progression-free survival. This trial was discontinued earlier because half of the patients with ADT therapy progressed on this treatment, so the study was discontinued early. Talking about quality of life, the patients with ADT or with enzalutamide, their quality of life was quite good and was the same. So adding enzalutamide with standard treatment does not worsen the patient's quality of life. Enzamet also analyzed what sort of additional benefit would patient give when they are receiving chemo during enzalutamide and without it. So this trial, I think, is one of the most interesting trials we have, because there's always a question if we add additional treatment for patients, more toxic treatment, will patients benefit? And the whole analysis showed that patients that received enzalutamide, of course, gained quality, gained statistically significant improvement in overall survival. But when subgroup analysis were made, patients that received docetaxel did not benefit in overall survival. So only there was only added toxicities, but no gain in overall survival. So patients that received docetaxel and enzalutamide at the same time gained only progression-free survival. On the other hand, patients that received no docetaxel but received only enzalutamide gained not only progression-free survival statistically, that was statistically significant compared to the standard treatment, but also there was a statistically significant improvement in overall survival. So I think from this trial we can learn that adding more toxic treatment for patients does not always give us benefit in overall survival, and treatment should be gradually introduced into the treatment after the fail of a first-line treatment. One of the trials, as I mentioned, the Stampede trial, I will talk about it a lot in my presentation. So Stampede trial is the only trial that actually tried to analyze which treatment is better, either is chemo or next generation androgen inhibitors. So it failed to, in this arm, it failed to show any significant improvement in abiraterone in overall survival, although it showed that abiraterone patients with abiraterone have a little bit better get better quality of life than docetaxel, and it prolongs the time to progression, but did not gain. The patients didn't gain any time in overall survival compared to the docetaxel. Talking about quality of treatment, of course, again, as I showed in Charters trial, that patients degraded their quality of life during initial treatment with docetaxel, but regained complete function afterwards. So as you can see, in later weeks after completion of docetaxel, patients had the similar quality of life compared to abiraterone or standard treatment with hormone therapy. Other thing I would like to talk about local treatment in metastatic hormone-sensitive settings. So there was 2 trials that basically we're using right now, and about talking efficiency. The first trial was a horror study, which showed there was no significant difference in median overall survival between standard treatment with ADT and adding additional local treatment with M1 disease. And STAMPEDE trial that showed that patients with low volume disease gain gain additional benefit from adding local treatment with standard ADT. But overall, there was no improvement in overall survival when the whole group was compared. Only the subgroups showed this benefit. And of course, as I mentioned, high volume disease did not benefit from local treatment. Other trials that are ongoing, and I think they might be discussed earlier within these days. So the one of the trial was SWOG 8002, which analyzes standard treatment plus definitive treatment of prostate cancer. So in this trial, I think it will be very interesting to know this the results of this study. Unfortunately, we will only be able to finally get final estimations in after a decade. So we'll have to wait for this study completion and integrating it into our everyday treatment of these patients. Other trial is PEACE-1, which is also very interesting. It includes a lot of patient groups which get a standard treatment of with ADT and even chemo, and afterwards it looks for does local treatment improve quality of life, and does introducing abiraterone into does have any significant effect on overall survival or progression-free survival. So again, we'll have to wait for results of this study for a decade. So after all this said, in 2022, we have quite easy situation in Lithuania because we have basically one drug, docetaxel, which we can use in metastatic sensitive settings. But as I said, in a couple of years, this might change a lot. So when our hands will be untied, one of the big question is what should we choose? And there, as you saw, there was done a lot of studies regarding this problem. So the natural question would be, what should we choose? So the answer is hard and is impossible to answer because there's a lack of head-to-head comparison in this sort of settings. So the doctors, when will be able to prescribe all of these drugs. So there will be a very interesting decision making. So in which there's not only the ADT, not only multidisciplinary team would say its word, but we will have to discuss with a patient what sort of treatment he would like, what he would be able to receive. So at this point, there's no significant data to show the benefit of one or other treatment compared to another. So as I said, there will be a lot of discussions when this treatment will be available in Lithuania. And on my last slide, I would like to show all the ongoing phase 3 trials. It's always makes me happy when I see so much potential drugs coming for clinical for medical oncologists, and which possibly might change of the way we treat the disease in the future. So as you can see, there's a lot of, I think I wasn't able to find them all. So there's a lot of trials and with a lot of with quite large sample sizes. And I think after completion of these trials, we will again have a lot of decision making, of course, when the reimbursement in Lithuania for these drugs comes.
Thank you very much for your nice lecture about metastatic castration-sensitive prostate cancer. Maybe have question from auditory? No. So, thank you once more.